Hello, everyone. I'm Patty Pellikka, Editor-in-Chief of JASE, and welcome to Author Spotlight for the month of November. It's my great pleasure today to be joined by Dr. Nils Sofus Borg Mogensen from Odense, and he's the lead author of a really interesting paper, Dobutamine Stress Echo in Low-Gradient Aortic Stenosis. Welcome, Nils. Tell us about yourself.
Hello, Dr. Pellikka. Thank you very much. It's a great honor to be here. I'm a PhD fellow at the Department of Cardiology at Odense University Hospital, and I'm currently doing my fellowship in cardiology in the region of southern Denmark. Doing my research, I have focused on patients with aortic stenosis, particularly those with low-flow, low-gradient aortic stenosis, both with classical reduced ejection fraction and with paradoxical preserved ejection fraction, under the excellent supervision of Dr. Jordi Dahl. And during my PhD fellowship, I have spent some time abroad in Quebec at the Institute of Cardiology at the University of Laval, IUCPQ, under the supervision of Dr. Marianne Clevel.
Well, congratulations on this really interesting work. Tell us about your study.
When the region of southern Denmark recovers about 1/4 of the Danish population, and all patients with severe aortic stenosis who are referred for aortic valve replacement are discussed in a multidisciplinary team of both cardiologists, thoracic surgeons, and anesthesiologists, and then the decision of preferred treatment is decided. When patients with low-flow, low-gradient aortic stenosis are referred for treatment, there's always a discussion about the valvular severity and the preferred treatment in these patients. And in general, all the patients with low-flow, low-gradient aortic stenosis are referred to Odense University Hospital for Dobutamine Stress Echocardiography, while those with preserved ejection fractions are referred to a cardiac CT for the evaluation of aortic valve calcification. As such, we saw an opportunity to delve into this research topic. So this study we have done is a part of my PhD fellowship, and we wanted to examine the safety of dobutamine stress echocardiography in patients with low-flow, low-gradient aortic stenosis and preserved ejection fraction, while also wanting to examine compare the results of both dobutamine stress echocardiography and the evaluation, the measurement of aortic valve calcification on cardiac CT in patients with low-flow, low-gradient aortic stenosis, regardless of the ejection fraction.
Yes, these patients really are a clinical challenge. The patients that have reduced ejection fraction and low aortic valve area, but a low mean gradient, and that causes a lot of clinical consternation. And so our guidelines have recommended doing dobutamine stress echo to evaluate these patients. What did you find?
Dobutamine stress echocardiography is safe also in patients with preserved ejection fraction. But we were rather surprised by finding that while patients with severely reduced ejection fraction have more eccentric hypertrophy of the left ventricle, then patients with preserved ejection fraction were more at hypertrophic cardiac myopathy, but not that much more than patients with ejection fraction between 35 and 50. We also found that dobutamine has the highest accuracy in patients with severely reduced ejection fraction and has a rather well adjudication with cardiac CT, while this is lower in both patients with ejection fraction between 35 and 50 and patients with an ejection fraction above 50%. We also found that the most optimal cutoff point for the determination of severity when adjudicated by cardiac CT was in fact lower than current guideline recommendations, especially for patients with severely reduced ejection fraction.
What are the next steps for your research?
In general, we want to delve more into this topic and research more why some patients, why we found these different threshold depending on LVEF, and why some patients have cardiac reserve and can get a normal flow, while other patients don't really normalize their flow, even in the presence of cardiac.
Excellent. Yes, I would encourage our readers to look at your article, which includes the detailed protocols and the responses based on ejection fraction and CT calcium score of the valves for these different groups of patients and the response to dobutamine. It's really nice work, and thank you for publishing in JASE. This paper was guest edited by Dr. K.K. Pohl, and he and his colleague, Dr. Sia, have written a very nice accompanying editorial. I'd encourage our readers to see that also. And thank you for visiting with me, Dr. Mogensen.
Thank you very much for having me.